Well, they have a very strong role, and the role is evolving as we get new tools added to our armamentarium. I would say the best risk stratifier we have right now is multiparametric MRI, which we utilize for that purpose. Using that, we can see tumors. We know that the negative predictive value for areas that don't appear to have tumors is anywhere from 90 to 95%, depending on who one reads. We can characterize the volume of the tumor and its aggressiveness. So it's very possible to, by looking at MPRI, determine if a cancer is a relatively indolent one or a more aggressive one. So it's a functional study, and I would say that is our best tool that we have at present. We also have genomic classifiers that can be utilized. Typically, we utilize these in the active surveillance setting. So for example, if a patient has what we think is an indolent tumor, we can take those a biopsy of the cancer and send it for a genomic classification, determine if that cancer is likely to behave more aggressively. That may push the patient into treatment compared to a surveillance arm. And to give an example, one way that I've used these genomic classifiers, which I think is an intelligent way to use them. So I had a patient that had 3 areas of cancer on biopsy. We saw them, we localized them. One was a Gleason 7, so we all agreed that needed to be treated, and 2 were Gleason 6. And typically Gleason 6s are slow growing and indolent, and we can follow them. But the patient wanted focal therapy. And I said, well, these tumors are located in different areas. I can't just ablate one because they don't cluster. So what we did is we asked one of these genomic classification companies to evaluate not the Gleason 7, because we all agreed that needed to be treated, but the 6s. We wanted to know if those would behave more aggressively. If not, we would watch them. So in other words, we would ablate the clinically significant Gleason 7, and then the Gleason 6s would be put on a surveillance protocol. Thereby, we would spare a lot of the parenchyma. The patient still kept on an active surveillance protocol and can potentially maintain their potency and urinary continence.